Okay, this is the Pharmacology Exam 2 Areas of Emphasis Review, and I've updated this with some of the Memorizing Pharmacology Mnemonics book content. That book is really going to be a bridge between pharmacology class and taking the NCLEX, USMLE, or NAPLEX, and I only used a couple of the mnemonics in here because there's so much information. Memorizing pharmacology by itself is meant to teach you 200 drugs, brand and generic, and then for NCLEX and NAPLEX you really need to know closer to 400 to 500 drugs, and that's what that teaches. So you'll see the difference, but I just put a couple in here just to make things a little bit easier. So let's start with the acronyms. You always want to know the acronyms, off the top of your head. You don't want to have to look them up, or even worse, you can't find them. So it's maybe important that I go over what an acronym is, an initialism, and then an initialism plus an acronym. So an acronym is when you say the whole word. So a SABA, S-A-B-A, would be an acronym because I said the whole thing. But if I said S-A-B-A, it's an initialism. So I'm using the initials just like somebody's initials. My initials are T-A-G, for example. But if I said it as an acronym, it would be TAG. And then an initialism plus an acronym would be if you said something like CDAD or NSAID, you're using one letter or a couple letters and then the acronym. So I'm not trying to get into linguistics, but I'm just saying that you want to make sure that you're saying it the way a health professional would say it, because you don't want to say HEFA, because nobody uses HF, they say HFA. They would never say, try to pronounce that. Okay, so let's go through them. SABA is a short-acting beta-2 agonist. Important to remember, we're talking about agonists here. Beta blockers would be beta antagonists. So those are for, while they're not really used as first-line hypertension anymore, it's certainly one of the examples that we see the most. And we remember that the TEROL at the end is the way that we remember a beta-2 agonist. Now we have to memorize which is the short-acting, which is the long-acting, and we do that by putting them in order when we put them on our flashcard, and you'll see that a little bit later in the presentation. Long-acting beta-2 agonist, salmeterol or salmeterol, I've heard it both ways, and then the TEROL again. There is an ultra-long-acting beta-2 agonist, and we'll see that as well. HFA, so hydrofluoroalkane, versus a chlorofluorocarbon. I know that not all nursing programs have a significant chemistry component, so the actual chemical makeup isn't as important as what it does to the environment. So a chlorofluorocarbon, which was a CFC, is actually damaging to the ozone layer. And it was cold, so it used to be when you had an albuterol, it would feel cold and it was working, just like when you tasted medicine, it used to taste bad. So this was phased out in preference for this, which is HFA or hydrofluoroalkane, and it's the propellant that allows the spray to come out of the albuterol inhaler and some other inhalers that have HFA at the end. COPD, chronic obstructive pulmonary disease, so we contrast that to asthma. So there's an irreversible versus reversible component. So CDAD, Clostridium difficile associated diarrhea. This is probably supposed to be capitalized, and then this is probably supposed to be italicized. But something that can be life-threatening. And then also coming from Clindamycin, same antibiotic, we have antibiotic-associated pseudomembranous colitis, another one of those acronyms that you have to know. MRSA, which we're saying it as an acronym, or MRSA as an initialism, methicillin-resistant Staph aureus. Again, this methicillin we don't really see in practice. It's toxic, but methicillin represents a drug that should work pretty well, even with the resistant bacteria. So this Staph aureus is especially resistant because it's resistant to methicillin. That's kind of the take-home. Tuberculosis, TB, just taking the first and the third letter from that condition. And then TCN from tetracycline, taking the first, the sixth, and this penultimate or second to last letter, T, C, and N. And tetra means 4, cycline means ring. So it's really 4 rings in organic chemistry. And I don't know if you remember the game Tetris, but Tetris had 4 blocks. So it was TETR from tetra, meaning 4, and then IS from tennis, because the guy who invented tennis liked tennis, or Tetris liked tennis. So it ended up becoming Tetris, and each of those had 4 blocks. But those are some of the acronyms that we're going to see in the second exam that have to do with respiratory or that have to do with immune/antibiotics and things like that. Okay. All right, well, let's start with asthma and bronchoconstriction. I pushed my mnemonic down a little bit, so I don't like that. Let's bring it up one. Okay. So asthma or bronchoconstriction or bronchospasm is one of the components. The other component is inflammation, and we'll talk about treatments for that in a little bit. But what we want to know is what are the metered dose inhalers that we can use to help with this bronchoconstriction. So an MDI is a metered dose inhaler. We meter it because we want to make sure that we know how many doses we have left. We don't want to have an albuterol with 1 or 0 doses left and the patient not know they have an asthma attack and then they have an inhaler that has no medicine. Okay, so MDIs in order and usage. The mnemonic is all save lungs. And the all allows us to put albuterol, which is ProAir HFA, again, that hydrofluoroalkane. It's a propellant. It's a short-acting rescue inhaler, and we use 1 puff, and then we wait a whole minute. So it's not just wait a minute, but literally wait a whole minute, allow some of the bronchospasm to relax, and then use the second puff. Levalbuterol is Xopenex HFA. It's supposed to be better than albuterol. I don't know if that's necessarily the case, but it's newer than albuterol, and it's kind of the same in terms of its ability as a rescue inhaler. So those two are the rescue inhalers. Those two are short-acting. So then we would put something that's more intermediate acting, and we call it long-acting because it was the longest acting until the Vilanterol came along. But then the S from SAVE is salmeterol or salmeterol. I like to say salmeterol just because the word meter is in there, and you can think of metered dose inhaler. But this lasts for about 12 hours. It's long-acting, and often we pair it with a steroid like fluticasone to make Advair. So you add salmeterol to fluticasone to get air for the patient. And those two come together treating both the bronchoconstriction and inflammatory components of asthma. We don't use salmeterol alone with asthma anymore. There was a trial that showed that the outcomes were actually poorer with it that way. Vilanterol in combination, it's usually in other medications, but Vilanterol is one of the newer every 24 hours ultra long acting, and this is for patient compliance. Patients will use albuterol regularly because they're having constriction, they're having some kind of attack. But if you're talking about prophylaxing and taking medicine consistently to prevent something from happening, there's not really anything that they really feel or that's happening. It's just like with blood pressure. It's tough to get blood pressure patients to take their medicine because they don't feel any pain. They don't feel anything coming on, so they feel like they're fine. But Vilanterol is the long-acting. And the key to this is that we put them in order of short, long-acting, and ultra-long-acting. There's also an L in Vilanterol, but unfortunately for long-acting, but because there's an L in salmeterol, levalbuterol, and albuterol, it doesn't really help us too much. Okay? But the All Save Lungs mnemonic allows us to put these in order, short, long, and ultra-long-acting. Now, an important component that we'll see is beta selectivity. And this is one of the other mnemonics in the Memorizing Pharmacology Mnemonics book. It's called the alpha-beta box, and I've actually shortened it down. I've taken the alpha out of this, so just to keep it in the respiratory chapter. But what we have is a box that allows us to put 4 different drugs in there and better understand beta 1, which affects the heart. You have 1 heart. Beta 2, you have 2 lungs, so that's an easy way to remember those two. And then an agonist versus an antagonist. So this is where, again, pharmacology is a little bit frustrating in that cardiac isn't till our 6th chapter of the, or 6th unit of the semester, but we still have to talk about it because it relates to beta 1 and receptors and things like that. So an agonist, again, is something that activates. So if you use something like dobutamine, you would increase heart rate. And if you use an antagonist, and you may have heard beta blocker, this is what we're talking about, it would decrease heart rate. But what's special is that this metoprolol is selective for just beta 1. So we can just put that here, beta 1. But this propranolol is going to affect both beta 1 and beta 2. And what does that mean? So if we have our alpha beta box mnemonic here, what we're looking at is if we have beta 1 an agonist, it'll increase heart rate. If we have an antagonist that only affects beta 1, then we decrease heart rate. That's straightforward. Where things get a little complicated is when we get to beta 2. So agonism, we heard before, the albuterol with the terol stem is pro-air HFA, and this increases airflow by bronchodilating or reducing bronchospasm. But then when you get to the beta blocker, if you have a non-selective beta blocker like propranolol, then you're going to affect beta 1 receptors and beta 2 receptors. So we would not use this one in an asthmatic patient. So we'll just put a little cross through that just to remind us not to use this in an asthmatic patient, since that's where we are in the chapter. But this box hopefully can help you keep straight beta 1, beta 2, agonist, antagonist, which ones we can use in asthma. So we would be okay to use this one in asthma because it's selective. We would be okay, obviously, to use this in asthma. It opens up the lungs. But we would not want to use something that causes bronchoconstriction. And then this one is completely unrelated in terms of respiratory. This is really for cardiac. Okay. So another medication that you can use to relax bronchial smooth muscle, besides something like a beta 2 agonist, is an anticholinergic. And usually we remember these anticholinergics from their side effects rather than their therapeutic effects. We see in here tropium. So atropine is, let's not put that way because that makes it look like that's the brand name, and that's not the case. So atropine, I'll just put it like a dot and get rid of this underline. So when you talk about an anticholinergic, we're really talking about a drug called atropine. That's kind of the drug and in the category. But instead of seeing tropine, which is tertiary, for those of you that took chemistry, we have tropium, which is quaternary, which means we have 4 connections. Okay, so but that trope, T-R-O-P, that lets us know that we have something that's going on with anticholinergic. So what we use is the abduct water mnemonic, and this lets us know what side effects we can expect. Now, ipratropium, it's local to the lungs, so we're not going to see it as much as we would with atropine. But in general, with an anticholinergic, we want to think dry. That's kind of our take home. And then abduct water, when you take away water or abduct it or kidnap it, things are dry. And then our side effects are A, B, D, U, C, T. So anhidrosis, where you have a lack of sweating. So when you put an A or an before something, it means not. So not sweating, not hydrated. Blurry vision, secondary to dry eyes, dry mouth, or xerostomia. And some people like to use Z-E-R-O, like meaning zero water in the stoma, which is the mouth. Urinary retention, so again, drying. Constipation, because there's no water in the bowel. And then tachycardia, you just kind of have to memorize that it's tachycardia for anticholinergic, bradycardia for cholinergic. But that's an easy way to remember some of the anticholinergic side effects you might run into when you see that tropine or tropium stem. Okay. All right, well, let's look at the inflammatory side of asthma. We have glucocorticoid examples, and although these aren't stems, you see the sone in fluticasone or budesonide, and those are clues to let you know that it might be a glucocorticoid, or maybe easier to just put steroid here rather than specific glucocorticoids. Fancy way of saying thrush is oropharyngeal candidiasis. So in the mouth and the pharynx, we see this thrush, because if you think of the suppression of the immune system that the steroid does, and then that we have a local suppression of the immune system, then you see something like candidiasis, which is that thrush that is an opportunistic fungal infection. I seem to have a little dysphonia myself, but hoarseness comes along with it too, so a little bit of change in the voice. And the way to avoid this candidiasis is to wash out the mouth. And my daughter likes to jump up on the sink and actually put her head under the sink instead of maybe using her hands or a cup, which is just her. Something parents are going to really want to know. Okay, so my kids got this asthma medication. Are they going to stop growing? I'm in a absolutely sports crazy town, especially for kids. So there's not going to be an effect on the endpoint height, but it may affect how quickly they grow, is what the data show. Okay. Moving on from asthma to allergic rhinitis. So allergic rhinitis is when we have allergy season and just all kinds of inflammation in the nose. We, instead of having to use a steroid orally like a prednisone, which has tons of side effects, we can administer it nasally, but we want to give it prophylactically. And again, prophylactically means before. So the old term for a condom is a prophylactic because it prevents pregnancy before it happens. So prophylactically is before allergy season. You might use something like fluticasone to prevent the inflammation in the first place, and it works a lot better this way. So in terms of glucocorticoids, topical versus systemic versus inhaled, it's just a lot safer to use it topically for sure, but then inhaled would be next, and then systemic is probably the least safe of them. And then oral prednisone causes tons of side effects, but two of them are mood and fat redistribution. So you'll see the buffalo hump, moon face, and then pot belly. So fat redistribution if you use it orally for a long time. But that's why we want to use these very localized steroids so that we're not dealing with systemic issues like that. And then Montelukast, single meaning one dose to get air. This is very rare, but because we give it in children so much, we have to watch for these mood changes and very rare cases, suicidal ideations. So something very, very important to watch out for. And you see in mood, the first two letters, MO, and then in Montelukast, you also see the first two letters, MO, to match those together. And then the Lukast alludes to the leukotriene inhibitor, its mechanism of action for helping with allergic rhinitis, and then also asthma and some other things. Antihistamines. So just a reminder from the GI chapter. The GI chapter, we had H2 antihistamines or H2 blockers. So we were thinking of something like famotidine, Tidine, but that's not the same as tudine. And it's actually, I think it's atidine because they had some trouble with another drug. So H1 is loratadine or brand Claritin. It's one example. And then tidine in famotidine is an H2 blocker. So just be careful because when you say it fast, it sounds identical. Tidine. But first generation versus second generation. So these first generation antihistamines make people very sleepy. It goes through the blood-brain barrier, and this is certainly not something we, truck drivers, bus drivers, our school bus drivers are taking their kids to school. They get allergies, and we don't want them to have to take first generation antihistamines to make them sleepy, but we want to know what they are. And just to kind of show you why I didn't really start implementing the mnemonics too much yet, because it shows you so many medications, and as we're learning it, we can just focus on one, like diphenhydramine, which is the one that we'll see the most. But then as you get to licensing exams like the NCLEX, USMLE, and NAPLEX, you need to know all of them. So the mnemonic for this one would be allergy A, B, C, D, rhyme. And so A is for anticholinergic, the side effects that you would see, and that was the abduct mnemonic before. Brompheniramine, which is Bromfed, chlorpheniramine, which is Chlorphen, and diphenhydramine, which is Benadryl. Three medications that we'll see often for allergies, and these are first-generation drugs, so they make them sleepy. And that's where the rhyme comes in. So the R for rest or sedation causing to remind you of the side effect. The HY for hydroxyzine, and we really see hydroxyzine for itching, and pruritus, things like that. And meclizine we really see for vertigo. But all of these are first generation antihistamines. And if you're going to remember enough for the boards, then, or you're an advanced student, these are the kinds of things that you're going to want to start focusing on, is making sure that you know all the drugs rather than just, okay, I know what Benadryl is, I know it's first generation, I know it makes people sleepy. Taking that next step towards the boards. The second generation kind of did the same thing, putting all the mnemonics together, and I don't think I underlined the stem here with loratadine and desloratadine. So if you're just kind of learning pharmacology for the first time, you know, it'd be fine to just know the kind of two that we're going to see the most, which are Zyrtec and Claritin, loratadine, cetirizine, maybe Allegra because we see it in children's medicines. Okay? But the second generation antihistamine, the big advantage, and anytime you switch generations, you should have an advantage, is that it doesn't cause sleepiness or drowsiness. So our mnemonic is non-drowsy, called for non-drowsy, using C-A-L-L-E-D and then this F for fexofenadine. So cetirizine is Zyrtec, and what I've done is, if there's something that came after it that's very similar, I put them together. But cetirizine is Zyrtec. The A is to avoid drowsiness. That's the advantage of the second generation. Levocetirizine is related to cetirizine, and so this is Zyzol. And then loratadine is brand Claritin. This was the first in the class that came out. And then the mechanism by which it doesn't go into the brain is entering brain prohibited. That's the E from called. And then desloratadine is related to Claritin, so we put these two together. And then fexofenadine, which is brand Allegra. The reason that fexofenadine doesn't have a partner is terfenadine was the prodrug, and it caused all kinds of effects as Seldane. So, but this is a safe metabolite of that. So again, not to blow you up with 5 when I could give you 2 or 3 examples. As we get towards licensing exams, we need to be able to know this many drugs, and it's just easier to attach them to a mnemonic like this. Decongestants. So when I think of decongestant, like really it's your ears pop when you're on the plane or whatever, but I thought nose pops or something like that to remember 3 of the decongestants that you would use. And we would want to kind of put them together. So you put together the 2 nasal sprays, the phenylephrine, which is neosynephrine, and the oxymetazoline, which is Afrin. And these are sprays that you can use, and they work really quickly, just a couple minutes. Where something like Sudafed, which is pseudoephedrine, this is a tablet, and it would take maybe half hour, an hour to start working. But also, this is the one that we have the issue with meth that has to be behind the counter. A lot of restrictions on this one. Okay. But with the sprays, we have something called rebound congestion. So if you use it for more than 3 days, the condition might actually get worse. So it's clear, but then all of a sudden, it's all stuffed up again. A couple ways to take care of that is you could try to use alternate nostrils until it gets better, or you have to give an intranasal glucocorticoid or steroid to get rid of that inflammation. But we want to just avoid rebound congestion in the first place, so use the nasal inhaler for 3 days. If it doesn't work, maybe switch over to Sudafed. The expectorants and antitussives. So an expectorant, again, is something that kind of thins the mucus, and then an antitussive stops the cough. The more powerful or the more regulated one is certainly guaifenesin with codeine. This would require prescription from a nurse practitioner, PA, or physician. And it's an opioid, so the opioid crisis, of course, makes it so that prescribers are very hesitant to prescribe these kinds of medicines. And to say it's addicting, it has a schedule that's certainly nowhere near Vicodin or things like that. But there is an addictive component that could be there with it. And then if you're over the counter, it's guaifenesin with dextromethorphan, Robitussin DM, or Mucinex DM. The combination meant to clear the mucus from the lungs and to help with dry, unproductive coughs. Okay. Intro to antibiotics. Just want to talk a little bit about the stems and what you can and can't do with them. Something like penicillin. This is one that you can count on. The psyllin stem in penicillin is going to tell you it's a penicillin-like antibiotic. So if you see amoxicillin or something like that, and you look at the end, you're like, oh, I see psyllin. That's a penicillin antibiotic. Fluoroquinolones, same thing. So the stem is actually the oxycin But if a fluoroquinolone, then you see the FL in front of it. So you might be familiar with ciprofloxacin, something like that. And then you can look at it, and that's going to be the stem that lets you know it's a fluoroquinolone. Tetracycline is a medication, but we don't see it too much anymore. You probably see minocycline more likely, or doxycycline, something like that. So I can bold this since I bolded the other ones. Thromycin, you want to be careful with this one, where you have something like azithromycin, a Z-Pak, azithromycin, and you don't want to say that anytime you see thromycin, it's always going to be something, because fidaxomicin is also a macrolide antibiotic, but it doesn't have thromycin. So we just want to be cautious with that, but know that these are little hints that we can use. And then monoclonal antibodies, something that we take the M, the A, and the B here to make the MAB that we'll see at the end of some medications. Okay, but that's just an intro. Be careful though. This mycin, it's going to tell you maybe it's an antibiotic, but it doesn't tell you much more than that. It just means it came from the Streptomyces strain. Okay. One of the ways that we use antibiotics is in peptic ulcer disease as a way to get rid of Helicobacter pylori, that helicopter-shaped organism we talked in the GI chapter. And that's amoxil. So the ACE mnemonic, it's probably Moxitag. Also, the ACE mnemonic is just that it's an ACE at destroying H. pylori, and we use the A for amoxicillin, C for clarithromycin. To antibiotics we'll use with some kind of acid reducer. And I just use esomeprazole because it's got a vowel and it makes it easy to make words with it. But you could be using any of the antibiotics. So we look for any kind of stems. So we see the prazole stem. We see that thromycin I just talked about. And we see the cillin, letting us know which medications are which. Okay. All right. Anaerobe versus aerobe. So if we're distinguishing our target, if we know that the organism needs O2 versus, that should be a subscript, versus not needing O2, which is the aerobe, that needs oxygen, and then anaerobe, no oxygen. And that really influences which medications we're going to use. Okay. Narrow versus broad spectrum. We always want to be careful with this broad spectrum because it kills a lot of the healthy bacteria. We could find ourselves with C. diff, or Clostridium difficile, or thrush, which is the Candidiasis fungal species. And we also want to be careful of resistance. So if we use antibiotics carelessly, we don't have good antimicrobial stewardship. We might see spontaneous mutations, so the bacteria mutate and the antibiotic doesn't work. And remember that the generations for humans, 20, 30, 40 years between generations, it's a couple hours with bacteria. So there's a lot of changes that can happen very quickly, whereas with humans, it takes a very long time for significant changes to happen. And then conjugation is the cause of multiple drug resistance. And this is, of course, a real problem where the bacteria shares its resistance with other bacteria. Okay. Well, let's start with the penicillins, more because they're the most familiar. The way that they work is they destroy the cell wall or make it weak. There's some injectable forms, and really we're always worried about that allergy adverse effect if someone is truly penicillin allergic, because there might be that anaphylactic reaction or something like that. Okay. In terms of gram positive versus gram negative, knowing that gram negative is when we have 3 layers, so that third layer caused it not to take the stain, versus gram positive where we have 2 layers and it did take the gram stain. And Gram was a guy or a scientist, so that's where that comes from. Beta-lactam, you'll see that penicillin is a beta-lactam antibiotic. What does that mean? Well, beta-lactam is just a moiety or a chemical structure that was in the penicillin. And it allows us to say, okay, well, these all are kind of similar because of their structure. So it's a ring, and it can be destroyed by a penicillin ACE. So a beta-lactamase is the general term, but when we apply it to a penicillin, it becomes penicillinase. When we apply it to a cephalosporin, it's cephalosporinase, and so forth. But I want to make clear it's the bacteria that releases the beta-lactamase to try to destroy the penicillin. So penicillin's the enzyme from the bacteria that destroys the ring. And we've got drugs that can prevent that, and that's that clavulanic acid down here that's beta-lactamase resistant. Maybe I put this in a not the best order, but MRSA is where we have altered penicillin binding proteins. It's a way for bacteria to show resistance. And then often we'll see, okay, well, huge case studies with all these factors, and really the bottom line is, why do you use one over the other? Well, why do you use amoxicillin versus ampicillin? Well, amoxicillin as an oral form has fewer GI effects, so that would be better for a child, especially if we're worried about dehydration. Ampicillin has an IV form, amoxicillin doesn't. So there's just, why would we use one over the other? Okay, and then so amoxicillin, fewer doses than ampicillin, and just kind of going through that and saying, all right, well, which one would we use? Why would we use it? What kind of factors do we have? Cephalosporins, very similar to the penicillins in terms of affecting the cell wall, except we have generations in this case. So first generation cephalosporins like cephalexin are going to have a very different profile of activity than a third generation like ceftriaxone. So that tri in there reminds you it's third generation. Or maxapine, the maximum generation before we got ceftaroline, which is fifth generation. And the big difference from first to third, fourth, fifth, and let me make this separation a little more clear, is that you can get into the CNS, so if you have meningeal infections, you're going to have beta-lactamase resistance. So while amoxicillin needed another penicillin in addition, we needed clavulanate in addition to the amoxicillin, it's just the drug itself at a different generation, so third, fourth, or fifth, and then gram-negative coverage improves generally as you go up the generations. Okay, but that's cephalosporins in a nutshell. And then there's some cross-sensitivity to allergies from penicillin. Vancomycin gets its own list because it is so important. And our mnemonic is Vancomycin Red Holmes. So Vancomycin, just a reminder of what drug we're working with. Red man syndrome, a deadly side effect that's possible, causes very high temperature. And then some of the therapeutic effects of vancomycin are hospital-associated pneumonia, osteomyelitis, meningitis, or M for covering MRSA, endocarditis, and sepsis. These are all things that vancomycin can work with at certain levels. Okay? The big concern is the infusion effects, infusing it too fast. And the reason that it works when penicillin might not is that it works a bit differently in terms of its mechanism of action. Tetracyclines and macrolides. So tetracycline literally means 4 rings, as I mentioned before. And doxycycline, minocycline, we see the cyclin stem here and here. Okay. And really here, but tetracycline by itself is actually a drug name. And the big thing that we'll see is chelation. So chelation is when you have a multivalent cation, and if you haven't had chemistry in a while or haven't had chemistry at all, multi just means more than one, and then valent means valence. So we're talking about the outer shells of these. So multivalent cations means that we have these pluses that are going to bind with something else. So you may remember like NaCl, Na plus, Cl minus come together to make NaCl, a simple salt. If you have sodium alone, you can go on YouTube and see this, you'll see explosions. And you certainly wouldn't want to have chlorine and eat chlorine that goes in the pool. But if you put Na, the explosive sodium, with Cl, the toxic, or not toxic, but toxic bacteria that you would put in a pool and put it together, you got something you can put on popcorn. It's very safe. But we don't want safe and ineffective when it comes to our antibiotics. So we look at the Ca++, Fe++, Mg++, Al+++. So the calcium and magnesium are the... so when we're going from left to right on the periodic table of elements, we're going to see 1 plus with the first column, which is hydrogen, lithium, sodium, and potassium. And then we go one more over to see the +2s. So this is when we're talking about beryllium, then magnesium, calcium, what we see here. Aluminum is on the other side of the periodic table, but still has 3 pluses because it's to the left of carbon. So not to get too into chemistry, the more important thing is that these are going to bind. But in a test question or on the NCLEX or NAPLEX, you don't usually see it like this. You usually see patients trying to take milk. Okay, so then you have to put, okay, well, that's calcium. Patients taking an iron supplement. Oh, that's ferrous or ferrum, which makes Fe. It's a magnesium antacid. That's Mg. And because there's manganese, we take the first and third letter to make Mg. And then, oh, okay, that's an aluminum antacid, so I need to know that aluminum is going to bind with the tetracycline. So it's not that the question is hard, it's that the question is hidden. The true question, which is, why is it that we're going to be concerned? We're going to be concerned because we get something ineffective at the end of the day. Okay? Clindamycin, we used to use this, or we use this if we have a patient that is truly penicillin allergic and needs some kind of dental prophylaxis. But really the adverse effects are what we talk about when we talk about clindamycin, Clostridium difficile, or antibiotic-associated pseudomembranous colitis. These are two conditions that we might see with clindamycin, these super infections over and above what we were originally trying to treat. Okay. The aminoglycosides, so these affect aerobic gram-negative organisms, and a good mnemonic to use, there's a couple of them, but the good mnemonic to use to know the activity and the side effects is amino from aminoglycoside. So A for activity, it's aerobic gram-negative, and that's a proper noun. Monitor peaks. So we need to monitor the peaks to make sure that we're getting enough medication, but we're also not being toxic. How does it work? It inhibits protein synthesis at the 30S ribosome. And then what side effects do we have? So the NO from aminoglycoside also remind us of nephrotoxicity to the kidney, ototoxicity to the ear. Okay. Then if we remember what the aminoglycosides are, we just use the NAT mnemonic at GNAT. So gentamicin is the one we see the most. It's really inexpensive. Neomycin, we see it's toxic systemically, but we see it topically, safe enough for children in Neosporin. Amikacin, we see the least resistance to. And tobramycin is kind of cool in that it has an inhaled cystic fibrosis, an inhaled form that we can use for someone that might have cystic fibrosis, which can be a condition that really welcomes infections, and it's nice to have something like tobramycin. Sulfonamides or sulfa drugs. So we see the sulfa, S-U-L-F-A, prefix, or we see the prim suffix in sulfamethoxazole and trimethoprim. They work as kind of a 1-2 punch to stop folic acid synthesis for the bacteria. We can ingest it, but bacteria have to make it. And so this allows a lot of selectivity for the bacteria because we're affecting something that the bacteria have to deal with that we don't. It's just like the penicillins. We don't have cell walls in humans, but bacteria do. And when we affect the cell wall, well, that's when we can be selective for the bacteria and not for the human. Okay? Some issues that we might have with sulfa drugs. So kernicterus is bilirubin in the brain. If you've been in a NICU and you're like, why are there tanning beds? Why is there UV light? That's preventing kernicterus or bilirubin in the brain. And then crystal urea, make sure to counsel nursing consideration is to have plenty of water so we don't get crystals in the urine. Okay, it can be very painful. Okay. Treatment for UTIs has changed quite a bit. So SMZ-TMP is just an abbreviation for sulfamethoxazole, taking the S, the M, and the Z, and the T and the M and the P from sulfamethoxazole and trimethoprim. It's first choice. Fluoroquinolones used to be first choice for simple UTIs or uncomplicated UTIs is maybe a better way to put it. Recently the FDA has said, no, save those fluoroquinolones for more complex UTIs because of the tendon rupture adverse effect. Okay. Sometimes we need to take into account the patient's condition or socioeconomic condition. If you have an indigent patient, and in terms of indigent patients and getting their medicine, even when we're talking about free medicine, you only have a 50% chance they're going to come back for it. So if they have something like a UTI, we might want to use something called monurol, which is fosfomycin. Mono meaning one, urol meaning urinary, just one dose for indigent patient that we're probably not going to see again. So we want to make sure that they get the medicine, that they get the full treatment, and the full treatment is to just give the one dosage. Tuberculosis, I won't go too into this, but the ripe mnemonic comes from the induration. So if you look at the induration of somebody that has TB, it seems like it's ripe, it's red, it's raised. But we just associate, there are tons of side effects with these drugs, but if we can just associate maybe one or two side effects with them, and then maybe what we do for them, it makes it a little bit easier. So R for rifampin, and then I should have probably bolded and italicized this to make it more clear that this is the mnemonic. Okay. And these are all in the book, but I just didn't want to blow things up by putting too much information in here, because the book is really meant as a bridge to the bigger licensing tests. So rifampin is red-orange urine. Isoniazid, we can see peripheral neuropathy, and this rare optic neuritis. The I's in isoniazid can help you think of optic, or the O for optic can maybe remind you of that. Pyrazinamide, we see arthralgias, which we could use NSAIDs for. And then ethambutol, we see optic neuritis, so that's why we don't use it under 6 years old. But RIPE for the 4 drugs we'd probably use for tuberculosis, rifampin, and that RIFA is a stem. Isoniazid, pyrazinamide, and ethambutol. The fluoroquinolones, so some things to know about them. We're going to see phototoxicity, just like we would see with the sulfa drugs. And we call it photosensitivity, so somebody goes out, gets burnt really badly. Or you'll see a list of drugs. If you ever go to a tanning bed or tanning salon, they have this huge list of drugs. This is one of them. And just like tetracyclines, we see this chelation. So again, the Ca++ dairy, the Fe+++++, ferrum, which is iron, Mg, magnesium, and then also the aluminum antacids. Moxifloxacin, rarely, maybe 1% of the time, it's actually a little more than that in a study they did recently, can cause hypokalemia. And it's more important to know how that is going to really cause an issue. So hypo meaning lower, kalemia meaning potassium. So why isn't, potassium P on the periodic table? Well, phosphorus is P. So they use the old Latin kalium, Kalium, for potassium. So that's why it's a K in kalium or kalemia. And DIG and potassium drug interactions is a real problem. If you have digoxin and hypokalemia, because of the way that it works with potassium, it could cause arrhythmias. So that's one of the big concerns that we have when we put those two together. And then metronidazole, probably should have mentioned this when we were doing the peptic ulcer disease treatments. But metronidazole has become first line in some of those. But we see this disulfiram reaction, which is severe vomiting, severe nausea. Disulfiram is a drug called antabuse to help someone who's having difficulty with alcohol stop abusing alcohol. And so we've just kind of taken, okay, well, disulfiram is the other drug that does this, so we'll call it against the original drug a disulfiram reaction. And then nidazole is the stem here. Okay. But what I wanted to give you was just an overview of many of the antibiotics that you're going to see, but also a way to kind of start working towards that licensing exam where you're going to have to expand your vocabulary. Now, one way to expand your vocabulary is by using these stems, like the floxacin to know that it's a fluoroquinolone, like using RIPE to know that these are the TB drugs. And there's actually another R, which I didn't mention, that we would use if there's a protease inhibitor in an HIV patient. But I didn't want to blow you up with too much information. I just wanted to make sure that we at least got a good understanding of how respiratory medications and immune medications fit into treatments, but also how we watch some of the adverse effects and some of the considerations that we have with our patients.